Hello, and welcome to In Service of Health, brought to you by the Public Health Accreditation Board. This is the podcast that brings healthcare and public health leaders together to inspire new thinking for healthier populations. In this episode, I was thrilled to sit down with Secretary Kody Kinsley. Kody previously served as Secretary of Health and Human Services in North Carolina, where he oversaw the state's Medicaid expansion, implemented a wide-scale social determinants of health waiver, and secured the largest behavioral health investment in the state's history. Now, Kody is Senior Policy Advisor at the Institute for Policy Solutions at the Johns Hopkins School of Nursing and advises national organizations and private companies on how to achieve better health and bipartisan solutions. So Kody and I sit down to talk about the importance of rural health, the importance of building and, quite frankly, rebuilding trust in public health, and reaching common ground to advance health in every community. I hope you enjoy this episode. Secretary Kinsley, it is so great to have you on the show with us today.
It's so good to be here. It's good to see you.
Absolutely, always a pleasure. So let's jump right in. There's a lot going on in the health space, so I would love to hear just all of your thoughts, all of your comments. It's going to be a great conversation. So first, I'd like to start with asking all of our guests, tell us a little bit about what motivates you to do this work. Kind of what's your origin story and why are you in this health space?
Sure. So I grew up in Eastern North Carolina, and my parents didn't have health insurance. My parents both worked for small employers that couldn't afford to give their employees health insurance. And so navigating the health system from a young age without health insurance was a really striking and poignant memory for me. And we had a number of kind of health events as you do when you're growing up, and the amount of stress and frustration that arose in our family and trying to figure out how to get care and what that looked like, and the stress that my mother faced and trying to think about the weight of the financial impact. I mean, that really galvanized me as a young person. And when I was in college, my father had a massive stroke that was really detrimental to our family and challenging for a lot of things. And really it was like the fear of the cost of the health system and how poorly that health system performed and trying to meet his need. I mean, this just really tragic stories that continued even into my college career, really galvanized me as like spending time and trying to think about how to fix the health system, how to make it better, and how to frankly just help people have some peace of mind, right? Nobody wants to spend time in the health system, but they want it to work when it's there. And so my passion for the work that I do now really rose out of those early experiences as a kid.
Yeah, thank you for sharing that. And I'm sure so many people can really relate to your story. And so, another theme of this podcast is the intersection between healthcare and public health. So tell us a bit more. You led public health in North Carolina. Why is public health in particular important to you? And why should it be important to society?
Yeah, it's interesting. I think sometimes we have created, to a degree, buckets here where we don't need to have lines. And I think we're fighting hard to really break down those walls. And, I see it in a bunch of places, right? And I think it follows how we try to mobilize to get services and support and focus. As we name something, we differentiate it from the other things that it is not, and we try to fight for it. But the truth is that the public, what they care about is health. I had a saying when I was secretary, which is like, if you have to understand my org chart, I'm failing.
Right.
Like if you're trying to figure out, like pick apart whatever, this, that, or figure out who reports to who to get to who to ask for a thing, like it's only coming from a place of like, you are not getting what you need. And what you should be getting to be healthy and be well and to live a fulfilled life. And so I think I apply that same thinking when I think about, we have a public health system, we have a healthcare delivery system, we have parts of that system that are financed through a Medicaid program, we have commercial payers, we have employer-sponsored elements of that, we've got a mental health system. Then when you start to dive into that, I mean, it's like, for a brief amount of time, I ran the mental health division of the department, and people wanted my business card to be one of those like postcard folding things, right? Because it was like the division of mental health, developmental disability, substance use services. It was like every acronym had to be said. And that's where I think we have to, as leaders, help people see the broader vision of like all of this drives into health, and we want to make sure that we focus. So in particular, public health is frankly a the oldest effort we've got. Clean water,
Yep.
safe spaces, core public health interventions that punch way above their weight as far as making people be healthy, and we have a separate healthcare or sick care system that delivers. And so I think the work we've been doing in North Carolina and many places, and I know you as well, are trying to bridge those gaps to really try to get the financing pieces into the public health pieces and get these more connected. We can talk about the health of people and not these separate systems.
That's right. And I love what you're saying. People often ask me, I'm an ER doc, why are you doing public health? Well, quite frankly, because I really just want to help people be healthy, and you can do that in a lot of ways. And it's also, our healthcare, sick care system, as you noted, we're not really getting the outcomes that we deserve, quite frankly. And so I think that's a really important point that you bring up. And so let's move into some specifics. You recently wrote a piece about opportunities to improve rural health. And we know that there are significant disparities that exist across the U.S., across many kind of demographics, but let's talk about rural health. 40% of rural counties in the U.S. are in a health professional shortage area. Of course, your experience in North Carolina, there's a large percentage of folks who are in rural areas. And we know that folks, generally speaking, tend to have higher mortality rates and lower life expectancy. So tell us more about kind of why do those disparities exist, and tell us about a little bit about some of the work you've done to address those disparities, and then what should we be doing? So that's a lot of questions, but go ahead and give us your expertise on rural health.
Bundle. Well, let me start here, and I'll give kind of a little bit of a personal why I care so much about rural health, and as you know, like being a leader in a large government organization, or frankly any large institution, like part of the greatest challenge that you have every day is to figuring out how to prioritize.
Yep.
Right? There's no shortage of things we can do, or opportunities to react to the public needs, but you have to figure out what are you going to focus on? How are you going to move the ball down the field? And how are you going to be responsive to the moment that you're in? And part of my core strategy and belief as a public servant has been to pick places where there's broad bipartisan work to be done. Mm-hmm. And that the energy that you get from the positive outcomes of success in bipartisan is what will propel us forward to the next thing. It's what we did around Medicaid expansion, around behavioral health work, around affordability. And as I was coming to the end of my tenure as secretary, I was looking out ahead, and I saw two big broad areas for bipartisan work to continue. One was aging, and we can dive into that more later. And the second was rural. And these are areas where everybody wants something about it. They kind of align to my core philosophy, which is like health and healthcare is not a red issue or a blue issue, and that is aligned to one party. It is a green issue. It is very responsive to financial incentives. And thinking about how that works. And I think put all that on the field to say, one, like focusing on rural is an important space because right now, gosh, our country needs places where we can all work together. Mm-hmm. Like we need to roll up our sleeves and do things together, and we need to bring down the temperature and be like, this is what matters, because no one in, rural Ashe County, North Carolina, gives a hoot and a holler about who you vote for when their health system is not available to them. That's right. They just want it to work. And so focusing there is key. Now, to your question about kind of defining the problem, I'm going to break this up. We had a healthcare delivery system that looked a certain way in the 40s and the 50s, like the post-World War II era, with the Hill-Burton Act kind of did an if you build it, they will come kind of frame for healthcare delivery. Like we actually, afterward, we could actually fix people. We could actually do some things. And the kind of institutional care made that possible. There was a way to pay for it, and these systems started to get built. Meanwhile, care has continued to change. Like more can happen at home. There's more digital. There's more trauma care. There's more prevention, et cetera, et cetera, et cetera. But those kind of legacy rural hospitals look the same. And they don't, and they're not sustainable. We've had people moving into more urban areas. The
Yep.
population base is getting smaller. And honestly, like you're like nobody, and you know this being an ED doc, nobody actually wants to be there, right?
Right.
Like, the people who are coming into you to see you, like it is not, they're not
Right.
happy about what they just did. They're not happy about what just happened. They're happy when you help them, but they don't want to be there in the first place. And
That's
and
right.
so we've got to think about how do we sustain access to health systems and systems of health that promote health in rural communities that look different from these legacy, because we can't sustain 70-bed hospitals in rural
Right.
communities, and that's going to take creativity, that's going to take prevention, getting upstream, that's going to take a better linkage into public health and the things that we know that actually drive health, that other 80% of people's lives.
Yep.
And to me, that's, it is why this area is so important, is because our legacy infrastructure is like hanging on by a thread. There's a lot of other dynamics that keep it the way it is, and it is time to leapfrog forward. And so, no, I do not believe that the Rural Health Transformation Program is sufficient as far as the funding
Sure.
to really get us over the hill here. It is not sufficient to make up the gaps caused by HR1 and the anticipated coverage losses potentially from that. But it is necessary in that we need to be thinking more creatively about how do we get to the
Yeah.
future of rural health, and now's the time.
Yeah, I appreciate that. And I love how you talked about focusing, finding common ground, common priorities. Well, let's dive into bipartisanship or doing things in a nonpartisan way in public health. It is unfortunate that a lot of things have become partisan in these days, but how do you? So for folks who are listening, and most folks, again, they don't care who you voted for. They just truly want the community to be healthier. That's why they get up. Public servants go to work every day. So what are some kind of tactical strategies or tools that you've seen work when you're in these rooms and just trying to get stuff done, quite frankly, and make the community healthier in a kind of heated partisan environment, if you will, that we are currently in the country?
I mean, I'll like pull back the curtain here and be honest with folks that like 97% out of 100 times, like, or 97 out of 100 times, like, we agree. Like people, like when
Right.
I've been in the room with legislators and other kind of political appointees that may come from a different party or a different background, like, we often agree. And where we agree almost 100% of the time is on the what, like what we want to achieve.
Yeah.
Where the disagreements start to blossom is how we get there.
Yeah.
And I think the opportunity is that we have to learn how to disagree better. We have to learn
Yeah.
how to, not question people's intentions, right? We can
Yeah.
judge maybe like, look, I don't really think that this path is going to lead to the outcome that we both want. Here's why I don't think it's going to work. But just because you think that's the right path doesn't mean you're a horrible human being. And I think that our politics broadly have kind of broken down into this place where we make kind of personal judgments towards people, and we even assign words like evil,
Yeah.
and that's not okay. Like we need to kind of honor that people come from their own background. So what I'm saying is, in part, I have found it is not as bad as people may think it is when you're
Yeah.
just watching cable news. B, it does take more discipline for all of us to choose not to be reactionary, right?
Yeah.
As a medical professional, you may agree with this. It is better to have a response to something, but not a reaction. Like if you have a reaction, that's not good, but a response, that's what we're looking for. And so kind of navigating that. The last thing I'll say here is, building relationships in advance really matters. I always say that if you want to borrow my car, it may be good that we have a relationship before you ask for my keys, right? And so if I'm rolling into a policymaker's office and I say, hey, I really need to do this, if this is the first time they've ever talked to me,
Yep.
then not a good thing. And so you got to work to kind of build relationships in advance to do that.
Yeah. And I feel like so much of what you're talking about, it's almost like, what I tell my kids, like, assume positive intent, learn to listen. These are like just basic qualities we want people to have. Sometimes our children do better than adults, unfortunately. But I also like what you're describing, which is really about this concept of trust. And it's not necessarily, that is definitely not a bipartisan thing. It's about trust in the public health system, right? Trust between a patient and their clinical team, their doctor. And so much of public health, effective public health at least, is rooted in trust. How can public health in particular work to, in some cases, quite frankly, build for the first time, but in other cases, build back trust so that we can really help improve health in our communities?
No, it's a great question. And I come out of a, operational management background, right? I mean, my career has flirted between kind of pure health policy and broad operational delivery of large systems. And part of what's core to that second piece, the operational piece, is a kind of a CQI, like a continuous process improvement mindset. And it starts with this basic premise, which is we can always do better.
Yep.
There is always, like, I walk out of every meeting I go to and I'm like, how could that have been better? Every presentation I give, how could that have been better? Like, constructive feedback to me is really valuable. And I think the same message starts with public health. And I think we hear this now around coming from many public health leaders, like, we can do better. We can work harder. And I think the challenge that our COVID experience really pushed us to is that this is a very large country. We have a very specialized public health workforce, and we have people that live throughout this country that feel very, very, very far away from those people's experiences. And how do we work harder to bridge the gap? I was speaking to a group of newly admitted students at the best public health school in the country, UNC Gillings, and and I said to them, like, this is a really good time for you to go do work at local and state public health. Like, get close to the people you serve. Like, the thing I learned spending time in rural North Carolina is that they don't trust you if you're not from there. Yep. They don't trust you if you've walked a day in their shoes at least. And so I think right now for public health, it's important for us to think about, how we build trust by doing and working with, gaining that operational experience. And then, thinking, I think going back to our core tenet in public health, which is like, my goal is to disrupt your life as little as possible and to still move you as close as possible to an opportunity for health. And that looks like layered approaches. It looks like meeting you where you are. It looks like giving you options. And it looks like educating you and trusting you. And those philosophies, I think, are really good philosophies for both how we rebuild and how we frankly turn down the temperature in public health right now on a lot of issues, and start from a place of, like, we know we can do better, and how do we appeal to people's desires that we should do better.
I love that. And there's 2 points that I want to kind of high five there. One is the importance of concordance, high five, the importance of concordance. And I mean, there is evidence around concordance, lived experience in the healthcare space, whether it's a physician who has similar lived experience as the patient. Community health workers, I would argue, is part of the reason why they're effective. There's evidence that they're effective is because of that concordance, lived experience. So that's really, really important. Another thing you were just speaking to my heart is this concept of CQI in public health. I promised to our listeners I did not ask or know that Secretary Kinsley was going to say this, but that is exactly what the Public Health Accreditation Board does. That's what we're about. That's why we were kind of created, was to really make sure there's this CQI process in public health and high quality, effective public health services throughout the country. And so critically important to just how you run an organization, how you operate, and just so critical, of course, to the Public Health Accreditation Board. So thank you, Kody, for emphasizing that. Let's talk a bit about meeting people kind of where they are, and how do you? And let's just double click a little bit about. You and I spoke before about this concept of harm reduction. Whether it's for substance use disorders, we've talked about other kind of big public health interventions, vaccines, et cetera. This concept of harm reduction, how has public health succeeded historically in kind of harm reduction practices? And how have we perhaps not done as well in some other spaces, for example, vaccination efforts?
So, I say we don't have to look that far back at an example that will be true to many people's memories, which is the work that we did and continue to do around opioid use disorder and broadly around addiction. I mean, public health led the charge in let's get the data to understand where these deaths are happening, and let's get the tool naloxone for opioid overdose reversal to reduce deaths. Like I can't save someone who dies, right? And it may take with a sickness and a chronic disease like substance use disorder many attempts. And so meeting people where they are, how do we reduce the other potential co-infections that happen, syringe exchanges, right? And it was really actually quite remarkable. Like you talk about bridging differences. And we saw this unfold in North Carolina. North Carolina was a place where there was a lot of kind of moral based, puritanical based views on giving people access to naloxone, even, and certainly syringe exchanges, and certainly drug testing tools, right? Because you're
Right.
kind of acknowledging that you're supporting someone's appropriate and healthier use of a drug. And there's a bit of an abstinence only framing there. And yet the data and the heartbreak around the deaths and the connection to these close-knit communities where this was happening allowed us to meet people where they were. Now, there's a lot of other nuance here as far as why we couldn't do this as successfully with other drug epidemics that have moved through society in certain communities. And part of that is a lot of other systemic issues that we're dealing with. But on this one, I think public health really showcased its ability to build out a harm reduction framework that is really powerful. I think, I was having a conversation with someone the other day about vaccines, and she was asking me advice on what she should say to her sister who is reluctant to get her child vaccinated for a number of things. And this person is not a public health professional; it's just her sister. And I just said, I'm not so sure you should say anything. Like, I think you should maybe ask questions as to why, and then just invite them to have conversations with their doctor or other people. And she was very upset and she was very agitated, and I get it. Like it's become a bit of a flashpoint, and I don't want any harm to come to any single child. But I also feel strongly, and I think we're in a place right now where parents feel really strongly that they have a lot of choice over what happens to their children. I think where it gets challenging, especially when we think about measles and now coming into the season for whooping cough, we're seeing deaths of children from exposure from other children who aren't vaccinated because the so incredibly infectious, and it's really tragic. But
Yeah.
I don't think the way through this will be forcing parents to do, or trying to figure out a way to force parents to do something who have serious concerns, right? Again, back to our kind of first principles here. Like, I'm not going to judge your intention. I think your intention is coming from a place where you really earnestly want to protect your child. But I do want to try to find the right people who you do trust, who you can ask questions of, and let you build with your own experience a different path forward here. And I think we've got to work harder to turn the temperature down and find a gentler way forward.
And I appreciate what you're saying, because quite frankly, the way to get someone to improve or change their behavior is not like beating them over the head with your 30-page report and your data points, right? It's listening. Again, these are just concepts of life. Quite frankly, it's listening. I hate to go back to how I work with my children. Like my teenagers, I can tell them all the things, but like until they get to that place themselves, they're not going to do it. It's just how it is, and that's just how people are. And so I love what you're saying about, as frustrating as it can be, and as much data and evidence exists, meeting people where they are, if your true goal is to get them to hopefully get the vaccine, you may have to move slow to go fast, which is very challenging.
And but one more thing on it, just to I think what is hard on this one is that few things are as impactful as vaccines from a
Mm-hmm.
positive perspective, right? Like
Yep.
one shot to essentially be able to eradicate diseases. The amount of negative things that come from those diseases. I mean, and that's why I think the public broadly right now is so kind of up in arms because around this, because it feels so hard to accept that people would not do the
Yep.
one thing that is so
Yep.
impactful. We have very few, quote unquote, kind of silver arrows in our
Yep.
quiver here, and this
Yep.
is one of them. But when I turn down the temperature on that frame a little bit and think about all the other things parents do to promote the health and well-being of their children, and if I were to line
Yeah.
this up alongside it, um, there are lots of other things that parents do that are not in the best interest of their children always. Like they may kind of
Mm.
intent, but there's a lot of other choices that are really hard that parents navigate through in life, and they just can't, muster those things through. And so I think, we have to, and how would we approach that? We continue to figure out, why can't they do those things? What support do they need? Do they need access to childcare because, leaving their
That's
child
right.
at home maybe not isn't the best thing? Do they need, do they need more steady employment schedules so that way they can pick their kid up from school on time, or they do have time in the evening because they're, able to support them? And how does the economic structure of our society?
Yep.
There's a lot of things, and so we, you know, I'll put on the D word here, Democrats. Like, I think a lot of us, think broadly, speaking for myself, or people who care about these issues, think broadly about, how do we create an environment that support parents to do the best possible things for their kids based off their intentions that we know are good.
Mm-hmm.
And I kind of want to lump vaccines into that same bucket. And I think it really matters that we continue to find out why parents have concerns and how do we support them. The last thing I'll just say on this is, like, look, the data is also clear. Like, the vast majority of parents support vaccination. Vaccination
That's right.
is the most evidence-based thing that we have. And, like, even when you double click on it, like, the states with the highest childhood vaccination rate is West Virginia. And so, like, it
Yep.
doesn't even line into the partisan places where people may think. And so, like, again, education is really powerful here.
That's right. And thank you for just drilling on that. Vaccines, incredibly important. We want everyone to get the vaccines that they're supposed to get. And there's a lot of positive things happening. Thank you on the
There are.
vaccination front. Let's talk a bit more about behavioral health more broadly. You were able to secure the largest behavioral health investment in North Carolina's history, I understand, $835 million. Tell us a little more about how you were able to do that and kind of what some of those initiatives were in North Carolina around behavioral health.
Sure. I mean, this starts with kind of this point of, like, picking the moment, right? Like, one of the great things being a leader of a large public sector institution is bringing this sense of stewardship to it, right? Like, I was not there at the beginning. It was there long before
Hmm.
I got there. It'll be
Yeah.
long after I'm gone. Like, the measure of my contribution is how do I, leave it better than I found it, and also how do I evaluate the moment that we're in to figure
Yeah.
out what we can execute on. I couldn't get everything done, but we got some really big things
Yep.
done because we were sensitive to the moment that we're in. And behavioral health was one of those moments. I mean, we had been fighting the opioid epidemic. More and more people were talking about mental health. COVID then happened, right? Everybody
Hmm.
experienced loneliness, sometimes leading to depression, fear, sometimes leading to anxiety. We had parents with their children looking at them, and their parents couldn't say, I've been through this before, I know what's going to happen. Like,
Yeah.
that's so
Yeah.
unnerving to a parent. That's so unnerving to children, kind of ricocheted through people's lives in such a challenging way. And I feel like just a little bit the wall of stigma around mental illness and substance use disorder started to crumble,
Hmm.
and the need to think, like, gosh, this is actually a health issue, not
Right.
a moral failing.
That's right.
We need to do something about it started to rise up a bit. And so we had this opportunity, because we were also at the same time working to expand Medicaid in North
Yep.
Carolina, to kind of pair these things together, to be like, one, unless you can get more coverage access, few groups of people benefited as much from Medicaid expansion as individuals struggling with substance
Yep.
use disorder. I mean, you talk
Yep.
about a tool to help get people healthy and back to work, Medicaid expansion.
Yep. Yep.
And so we were able to get some extra dollars from the Medicaid expansion
Okay.
initiative, and that helped fund. But this is where I want to give credit to my supermajority of Republicans in the North Carolina General Assembly, which is that they could have put that money anywhere, right? They got $1.8 billion, what I call the signing bonus. They put pretty much every single penny of it towards health, 835 million of it towards behavioral health, the rest of it towards allied health workforce, construction at community college for allied health workforce programs. I mean, the only thing that the press made a fuss about that didn't go to health was a bathroom at a speedway. And honestly, like, as far as the price of getting expansion done, if like that was the toll, like I'd pay it any day. And I still maintain that bathrooms are public health. And so I feel good about it. But that's how the other piece of how we got there was that the public wanted it. I mean, nothing is more powerful than public sentiment, and that experience during COVID. I traveled around the state with a collection of state senators and state representatives, and we held town halls. And I think one of the happiest moments for me was when we started to actually roll out the investments and the efforts and the infrastructure that came from that 835 million. They were deeply responsive to what we had heard the public say years before. And so to see that feedback and to go back into the community and say, here's the thing you wanted, here you go. And we did this together. Like that's what governance and public service should look like.
Absolutely. I love that. And, the Medicaid expansion, North Carolina was, I believe, the 40th state to expand Medicaid. So kudos to you for leading that charge. Can you also talk a bit about some of North Carolina's work in addressing social determinants of health, which has also been kind of a national model? Can you talk a bit about that and some of the outcomes that North Carolina saw from that initiative?
Sure, totally. So, it is not new information to most people, and that, what really promotes health and well-being is not what happens at the doctor's office. Like, the doctor's office, the emergency room, these are places that when I do get sick, help me get back to healthier faster, and patch me up. And I'm so grateful for them when we need them in our system. But as far as preventing those illnesses in the first place, it looks like, of course, those public health preventions like vaccines, but also access to healthy food, good transportation, employment, safe relationships, clean air, clean water. And yet our healthcare system pumps, trillions of dollars into the sick care side and not a lot into the prevention side, unfortunately. And so North Carolina Medicaid, and give a shout out to my predecessor, Mandy Cohen, who was the architect, and then Betsy Tilson, who is our state health director, who is really kind of the heart and soul of pushing this work forward, got approval to use Medicaid dollars for the first time ever to pay for food, transportation, housing supports, in an effort to really measure like what turned the dial on health. And it took us a little while to launch it because of COVID, but when we got going, 2 years in, the results were remarkable. We found that people that were participating in the pilot had, first and foremost, their needs were getting met, right? So I mean, that's the most straightforward. Like before they said they struggled getting access to food, et cetera, et cetera. Afterwards, they weren't struggling. So, okay, at least the service delivery was working. But then more magically was that we saw a statistically significant reduction in emergency department visits of these folks, right? If you're living with 2 or 3 chronic diseases, you have diabetes, heart disease, all of a sudden having healthy food, it makes a difference. And not going to the ED, also not getting hospitalized, like healthier at home. And you and I both know how expensive 1 second at the hospital is. And because it's so expensive, reducing it saves so much money, right? The key to one of the keys to affordability in our affordability crisis in this country is reducing chronic disease and reducing the need for hospitalizations and expensive care. And this program has done that. And so much so that even when you add in the entire cost of the food delivery and all the other things we did, we were saving over $1,000 per person per year on the program just because we were driving down utilization so much. And what's spectacular about that is, when you think about like health insurance premiums and what you pay,
Yep.
like that's real money. And applying that more broadly and doing more of that is what we need to be doing in this country.
On that point, whether it's addressing social determinants or prevention, you and I know that unfortunately that is not what our healthcare system pays for. And sometimes you have to put money into the system for those things, and you see the cost savings, if you will, later down the line. So what do you say? These are challenging times. Margins are small if you even have a positive margin in a health system. What do you say to health system leaders today who are looking at perhaps not being able to, or people losing their Medicaid insurance, rural hospitals looking at potentially closing? How do you talk to a healthcare leader about really pushing them to make these investments in upstream interventions, social determinants, in a time where budgets are dwindling?
Yeah. So, I call this the wrong pocket problem. And the wrong pocket problem kind of pops up in a lot of different places. It pops up whenever the benefit accrues far down the road or to a different system,
Mm-hmm.
then it's really hard for people to kind of justify the upfront investment. I mean, we saw that in the work that we did at the Department of Health and Human Services. Like if I could promote better substance use disorder care, then that created more tax revenue for the state because people were working. That created less utilization of jails. That created less
Yeah.
utilization of other local services that accrued benefits to the local government, and those dollars didn't get back to my bottom line.
Yep.
Right now, we're public organization interested in long-term public value, and so different motivation, but the same problem applies. Oh, well, and by the way, one more thing on that, like this also makes the governance conversation hard because
Mm-hmm.
the appropriation of those two different buckets of money, justice system versus health system,
Yep.
fall into different committees at the state General Assembly level, different committees at the federal level, and so getting the money to move between those spaces, there's some general, core wrong pocket problems
Yep.
all the way up to the highest ways that we appropriate dollars in this country, and then it just gets worse after that, right? Then it's a health system that can't bill for what you're doing, a payer who may not insure you by the time your chronic disease becomes a problem,
Yep.
all of these things. And so the first and foremost thing that I would say to all health systems is that I know that they're in the work that they are in because they care deeply about the people they serve. Like the motivation. You talk to anybody that's in the health system, they are there. But the incentives that are in front of them to like survive, like I've heard the phrase so many times, no margin, no
Yep.
mission.
Yeah.
The incentives that are in front of them every day are really hard. I think the responsibility is incumbent upon the ultimate payers, meaning government for
Mm-hmm.
Medicaid, Medicare, and ACA
Yep.
subsidies, and employers as folks that cover, the majority of people in this country get their health insurance through employers to think about how did they do the longer term investments and how do they realign those incentives to make that different for the health system, and how do we work harder to do that. However, I will say that the transformation from where we are now in this kind of cross subsidy business in the healthcare delivery system
Yeah.
to where we need to be is a painful one. And so we will need all healthcare providers to kind of acknowledge that like it may not look like, if we're really good at prevention, we need less hip replacements, someone's going to lose out on that.
Yep.
And
Yep.
those interests are the challenge that will change.
Yeah, that's right. And certainly our incentives in our sick care system are not aligned. And quite frankly, we're not seeing the outcomes. Even the healthiest among us could be healthier if we actually had a system that actually worked and focused on prevention.
But I will add here that I don't want folks to think like all is lost. I had the
Yeah.
privilege of going to Taiwan recently on a kind of delegation of health officials to visit the Taiwanese government, and
Yeah.
we were meeting with their national health insurance, and this is a country that they do have a single government payer, so everybody is insured by the
Sure.
government, but they have private providers. So the vast majority of providers are
Mhm.
private, and so It's not, they would tell you it's not perfect. Like their providers are frustrated because they don't really have any leverage to negotiate better rates. They get what they get, et cetera, et cetera. But they have, really high employment of these providers because in part they don't pay for education, et cetera. But so the total cost that they pay per person in US dollars for their healthcare delivery system is like $1,400 per year. And they're like, and that's like a tenth of what we pay in this country, right?
It's impressive.
And they're like really pissed about it because it's out of control. It's too expensive. It's going crazy. And they don't have any like front door utilization management. You can go to a specialist, you can go to whatever, you can go to Eastern medicine, you can get acupuncture, it's all covered. And it's still like that, they're trying to get people to go the primary care route. And so more so they like increase the copays a little bit. The copay, I think the copay is like $7, $7, and so all of it's kind of all relative. But so we're having these conversations and we're, the two big things that like hit me in that conversation were one, like I kept getting stuck on this issue of scarcity, right? Like how or the kind of a scarce framing, like how do you, if you've no front door, if utilization just create, can you control costs? And it's like, well, in the end, what we got to a deeper understanding was like, look, in this country, like access to the healthcare system is not a privilege. Like you don't hit your deductible and then all of a sudden go crazy because you finally hit your deductible that year. This is no deductible, right? Like we treat health and in the health system in this country like a luxury good. And so people like utilize it like it is a luxury good, whereas they're like, back to what we were saying earlier, like nobody actually wants to go to the doctor. They don't want to spend time there. And so, that was a big aha moment for me. Like, how do we kind of like get over the hump of people kind of getting to that place? The other piece that was a big aha for me in that visit, which ties back to this conversation, is I asked them, where do they look for innovation? Like if they're trying to control costs, they're trying to improve outcomes, and they said us. They said the United States. They said CMMI at CMS. That the pilots, like they're implementing right now global budgets for their hospitals in Taiwan based off the global hospital budget that we have in Maryland and the AHEAD model that other states are now looking at specifically for rural communities, that we can have more transparent pricing and then we can base it on cost across the entire system, and that you should get the same payment regardless of service in the same site. And those modernizations to improve quality and to lower costs are coming from us. We have a lot of great examples of things happening in this country. We just do it in a very patchworky way, right? Like it's not one big beautiful tile floor. It's just little shiny tiles here and there. That's right.
That's right. Thank you for bringing up that example. And you're right. There are so many great things happening in the U.S. and we just need to do a little better at making sure all people have access and we improve health outcomes. So thank you for that. It's been such a nice conversation with you, Kody. So thank you. In closing, last question for you. What is the one actionable tip, resource, piece of advice you have for healthcare leaders who are just really trying to do some good, trying to improve health outcomes?
Well, I'm going to give you two. So I'm going to give you like my message to just health leaders that are listening, and the work you're doing. I think my primary message is do not be discouraged. I know it can feel right now like a tough time. A lot is changing. Federal policy changes could really disrupt coverage in this country. There's a number of other things that we've been fighting for, and it's easy to get discouraged and frustrated. But I will tell you what Brian Stevenson says when I had the opportunity to meet him when I went down to the Equal Justice Initiative, which is that the greatest tool that we have is hope. And then without hope, we have hopelessness, and that is not going to get us where we need to go. And, it has been out of some of our greatest areas of challenge where we have risen to the other side to some of our greatest accomplishments. So now is a time to be really sensitive to public sentiment, right? Like why are people okay when we're seeing some of the changes happening to the public health system and to the health system broadly? Like why is that, where's the fuel coming from? How do we come up with a better vision? How do we be more responsive to the people's needs? How do we offer that vision to them in a way? And how do we, on the other side, if things do crumble, how do we rebuild it better? What does that look like? Now is the time to be thinking about the future and to be better understanding and to connecting with people, to reaching across difference. And, our health leaders have to lead the charge there. And this kind of up and down and circuitous nature is not a bug, it's a feature. Like, it is a feature of democracy. It is a feature to who we are as a people. Yes, I believe that the moral arc bends towards justice, but I think it looks more like a crab walk than an arc. and I think we've got to kind of, as a Cancer, my birthday's in July, we have to kind of ride that crab walk here and stay positive. My bigger kind of message that I will give that is my current kind of point of frustration is, like, I think we have to give up on patient responsibility. And this is kind of speaking more to our policy friends listening. Like, medical debt is the leading cause of bankruptcy in this country. Like, the effort to control costs in the system through copays and deductibles and all these other things is not working. Like, and we have seen the fights between large payers and large providers, and they inevitably do benefit design where deductibles go up and copays shift, and we pretend to think that individuals in the middle of having a heart attack are going to go price shop, and that is not how that works. And if we want to think about how to realign, from a management perspective, like, I align decision authority with the people who own the risk. And the people who can really navigate the risk in the system that we have are the big payers and big providers. And holding people harmless, I think, is really important. And I think this also fits into the first comment I made, because I think a lot of the public sentiment and frustration that is fueling the upset in our health policy environment right now comes from the fact that people are more frustrated than ever before. My mother, 40 years ago, navigated a health system that was really hard and really challenging. Fast forward 40 years, all the gains we've made in coverage, all the other gains we've made, her life is harder today than it would have been then in navigating the system. And so let's get rid of patient responsibility. Let's stay hopeful and continue to vision a future where we all have the opportunity to be healthy and well.
Secretary Kinsley, thank you so much for sharing your wisdom with us. Really, really appreciate having the conversation with you, and thanks for joining us.
Privilege has been all mine. Great to see you.